this is our last lecture. This lecture will cover the end of chapter 16, which is on biological and psychological therapies for mental disorders. We've talked about psychodynamic therapy, which is like the original form of psychotherapy. And it leaves a lot to be desired. It's based on some very questionable assumptions. These assumptions are unfalsifiable. They're arguably very misogynistic and involve a kind of power relationship between the therapist and the patient that doesn't give the patients a lot of agency or sometimes even respect. There's an alternative in humanistic therapies that instead of seeing somebody as like broken and disordered and mentally ill, looks for the good in them and tries to support them to thrive, to adjust in their environments, to question things like conditions of worth. Then we talked about behavioral therapies. Psychology is ultimately a science of human behavior. We learn behaviors. Our behaviors are maintained in certain contexts through associations, through reinforcement, through punishment. Well, punishment doesn't maintain our behavior. Behavior is maintained through reinforcement, and then we might not act in ways that we ought to that are adaptive because of contingencies like punishment in the environment. So behavioral therapy would look at that and try to alter those contingencies. Ultimately, all the different kinds of therapy are about trying to get somebody to behave, to think or feel in ways that are better adapted to their environment, that are more adaptive. Mental disorder is at the bottom of it about maladaptive behavior. So whatever the therapy, we're trying to get people to act more adaptively. The most kind of modern evidence-based therapies are called the cognitive behavioral therapies, and they combine cognitive and behavioral approaches. So cognitive therapies would assume that your thoughts matter. Think of somebody who's depressed. They might have irrational thoughts, maladaptive thoughts. Everything is terrible. I'm worthless. I can't do anything. Everything's hopeless. I'm a burden. Now, maybe a therapist could intervene to help adjust those maladaptive thoughts. So that's cognitive therapy, and cognitive therapy can be made even more effective by combining it with behavioral therapies. One of my favorite psychologists ever is Albert Ellis. Albert Ellis is the founder, pioneer, something called rational emotive behavior therapy, which is a cognitive behavioral therapy. But what I really learned from Albert Ellis, which I have tried to teach in every psychology class I've ever taught, is related to conditions of worth, which is something that what's his name, Carl Rogers, also identified as maladaptive. Albert Ellis had a strong view that a lot of disease and disorder comes down to conditional self-worth. People trying to have high self-esteem by meeting some condition, right? Like by having enough money, by being beautiful, by being accepted. Someone has their microphone on. Please make sure your microphone is turned off. I've been hearing it for a while and I can't see where it's coming from. Okay, I don't hear it anymore. Nope, there, I still hear it. Who has their microphone on? You end up sort of getting taped if you leave your microphone on. Don't do that. I can't find it. Maybe it's been turned off. All right. back to Albert Ellis. So Albert Ellis is a clinical psychologist. He's seeing all these miserable people and finding out, why they're like that. And what he realizes is that it often comes down to some irrational belief. And that irrational belief is basically about what Rogers would have called a conditional of worth, right? Some contingent source of self-esteem. And you can never win by playing that game. Let's say that you based your sense of self-worth on your accomplishments. You will never have enough accomplishments because your accomplishments are never ever going to fill that hole. They're never going to really answer that sense of deep yearning that is not actually for accomplishments. It's for a sense of worth. And at the end of the day, he thought that the only thing you could do was just give it to yourself. Just decide that you are worthy now. With whatever you have, with whatever you do, with whatever you are. And that means that your worth is the same, whether or not you fail this class or pass this class, are accepted or rejected by the beautiful girl you ask on the date, whether or not you are hired for the job or fired for the job, whether or not you are the model citizen or in jail for something highly stigmatized. Your worth is always the same. And he also encouraged us to see other people that way. And this eliminates a lot of unnecessary misery. It eliminates a lot of unnecessary conflict. It suddenly makes it easy to receive feedback on a behavior. He was against rating yourself. Right? Never rate yourself. There's no criterion on which you can do that fairly or rationally, but rate your behavior. Rate the way you studied for your midterm. Maybe there's some way that could have been improved, or maybe you're satisfied with it, but don't ever rate yourself. So Albert Ellis pointed out how an outcome isn't simply caused by some event. It's not that you're depressed because you failed the exam. It's not that you're depressed because you were rejected by your crush. Right? That's the activating event. Right? Okay, you get a bad grade. Okay, you get dumped. But there's nothing that makes it necessary that you therefore wind up depressed or angry or anything. That is mediated by some belief. In this case, so here's somebody having a sort of depressive cognition with their bad grade. I'm feeling really depressed now. I'll never succeed in university. That's like an outcome. What does it come from? It comes from assumptions, from beliefs, a way of thinking. Okay? And somebody else could reframe this failure in a totally, or low grade, in a totally different way. You can give the same stimulus, let's say a grade of B, and different students will have totally different reactions to it. Okay, somebody else is thrilled with, one person is thrilled with the B, and another student is like devastated. And that depends on their beliefs and their expectations. And so if you want to help somebody that's having this, let's say, depressed outcome, you can try to get to the bottom of the cognition that's irrational and help change it. Okay, so he thought that your vulnerability to psychological disturbance is basically a product of the frequency and strengths of your irrational beliefs. And then he said, okay, so you have an irrational belief. What can we do about it? You could dispute the belief and replace it with one that leads to more effective or adaptive behavior. That's ultimately the measure of whether or not this belief is serving you. Aaron Beck is another famous figure in cognitive behavioral therapy. I think it's more on the cognitive side, though. CBT approaches are kind of the best forms of psychotherapy we have. That said, there are mental disorders that are of a much more biological, hereditary type nature, like severe depression. With severe depression, maybe there's more than just irrational beliefs and maladaptive behaviors going on. Sure, that may be part of the problem, but there could also be some kind of chemical imbalance. Or that may particularly be the case when bipolar disorder and their manic and depressive episodes. So there are some conditions that really need medical pharmacological treatment, but they still also benefit from getting CBT on top of that, for sure. And can even help them with adherence to treatment, for instance. So the combination, when it comes to conditions that are more like biologically caused, what's usually best is a combination of medication and therapy. Then there's, other conditions that are more about the way you're thinking and what you've learned, like milder forms of depression and anxiety that could respond completely to CBT without any medication. There is a third wave of CBT that's based on an understanding of values and on the idea of acceptance. There is acceptance and commitment therapy, and dialectical behavior therapy are examples. Dialectical behavior therapy is used for people who are at high risk. For example, risk of, say, suicide or acting out impulsively. It's used in the treatment of, I think it was developed for the treatment of borderline personality disorder. It's used with folks who are suicidal. It offers a higher level of support such that patients would be able to contact their therapist sort of after hours, or so it's a higher level of support. It's not like you have a session and the person's like, okay, bye, see you in 8 weeks. So there's a higher level of support, and there's also more support for the therapist. So the therapist would have almost like group therapy for themselves, because it's hard to support people who are having severe disturbances, and they might sort of discuss their cases with other practitioners as well. Has anyone, sometimes there's students who've had dialectical behavior therapy and they're interested in and want to talk about it. So if you've tried any of these things and you want to share, you're certainly welcome to do so now or after the lecture when I have turned off the recording. In DBT, there's support for social skills, right, for managing impulses, for more adaptive responding, as well as for the irrational beliefs. In borderline personality disorder, one of the traits is a practice of splitting, seeing somebody as all wonderful or as all terrible. And a person could be sort of coached to think of it kind of more rationally, more fairly, and in a more balanced way. How does this come back to acceptance? Oftentimes in cases of mental disorders, people are strongly rejecting things about it, right? Maybe even to the point of depersonalization or denial, repression, like rejecting their memories, rejecting who they are, rejecting their identities, rejecting the things that have happened to them, rejecting their negative thoughts and feelings. There are people, I remember once somebody coming who was interested in counseling with me, and she said to me, you know, she'd had some struggle with alcohol as well. Said, I just want to feel good about myself. Almost like she was asking me to get rid of her unpleasant thoughts and feelings. Wouldn't it be more powerful to cultivate distress tolerance, to accept that you have unpleasant thoughts and feelings and that they have adaptive value? Imagine if you could not feel anxiety. Imagine if you could not feel pain. There'd be nothing to stop you from doing foolish things with catastrophic outcomes. Imagine if you couldn't feel sadness. Well, then, sadness is often a reaction to loss. Then you can't feel love. If you don't feel anger, well, do you have any boundaries? Because anger is a reaction to your boundaries being violated. Anger connects to your sense of justice. So if you never get angry, does that mean you're okay with everything? Is that good? There are people who, so a lot of people want to seek therapy because of their suffering, right? And they want the suffering to stop and to end. But is there any adaptive value to suffering? Does integrating it and learning to tolerate it help you become, say, a stronger and a more effective person? A lot of the maladaptive substance use behaviors people end up in, like, addictions to alcohol or opiates, are about trying to escape suffering, to make it go away, to not deal with it. But what if instead of getting rid of it and avoiding it, we accepted these difficult thoughts, feelings, experiences, and then tried to move forward constructively from there? So the idea of distress tolerance recognizes that living a life that's aligned with your values. A good life is what? Well-being is what? It's prudential value. It's achieving your values, living in alignment with your values. In order for you to do that, you are going to have to suffer. It is actively distressing. And distress tolerance recognizes that you can suffer and still engage in values-based, goal-directed actions. Let's say it is, generally speaking, the right thing for you to show up for your midterm and write it. But you have severe anxiety about it. Some students might say, I can't write the midterm because I'm so anxious. I can't ask my crush out because I'm so anxious. I'm too anxious to do it. If only I were confident, if only I could get over my anxiety or my insecurity, then I could do it. But here's something better. Write your exam anxiously. Ask your crush out anxiously, with your voice shaking, your knees trembling. The anxiety isn't really a barrier. You can do what you need to do to live a life that's aligned with your values, that's moving in the direction of your values, anxiously, sadly, and angrily. Courage is not about the absence of anxiety. Courage is what you have when you show up with your anxiety beside you. So acceptance and commitment therapy focuses on getting people to kind of accept the reality of their circumstances, to accept that they have unpleasant thoughts and feelings, and to move forward with values-based actions from there, right? In a committed way. Committed to what? Committed to values. CBT tends to rack up better than the psychodynamic and humanistic therapies that are based on a lot of assumptions. They're really subjective. What is self-actualization? How do we measure that? For depression, it's as effective as drug therapy. Often it can be good to combine both. However, drug therapies you might think of as like a kind of second line of treatment. If you can treat some kind of disorder, some kind of problem just through psychotherapy or through lifestyle changes like exercising and getting a good sleep schedule, do that first because it may solve the entire problem. Remember, sleep deprivation is a strong predictor of depression. So the first line of defense should usually be, unless it's something really serious like schizophrenia, like lifestyle-based and psychotherapy. And then if that doesn't solve the problem, it's appropriate to look at pharmacological interventions. And sometimes those are very successful people, right? I know people that are just like, wow, I got on this antidepressant and it changed my life and all is well. My mom is doing so much better on some antidepressant or anti-anxiety because before that she, you couldn't get through to her and she wouldn't eat and she wouldn't sleep and she was losing weight and going down the drain. Yay, tricyclic antidepressant worked for her. But there's also risks. There's also adverse effects with pharmacological treatments. Many of them are, we don't really know how they affect the brain or the body years down the road, right? There's randomized control studies that are those highly controlled experiments where you randomize people to groups and all that. They're very expensive and you can't run them for very long because people start dropping out of the study. And you can run them for like maybe a year tops. So I can't tell you what the potential risks are of taking stimulants for your ADHD, that you might experience when you're 50 or 80. I just don't know that. Many of them are so new that data doesn't even exist. You can avoid that risk by using cognitive behavioral sort of psychological strategies. However, there are certain cases where medication is absolutely indicated, right? If somebody's having psychosis, for instance, right? Like, please don't try to treat that with psychotherapy. You might ask, how do we know? How do we know that psychotherapy is effective? There's a big missing piece here, and it's like, effective for what? Because different kinds of psychotherapy are actually more effective or less effective for different problems. In general, psychotherapy is more effective when you have a specific, well-defined problem, right? I don't know what I want to do with my life, and I want to choose a career. That's like a specific problem that you can work on. Or I'm so sad I can't get through my day. That's a specific problem. But some people go into therapy with just like general malaise, right? And they don't really know what they want. They don't really know what the problem is. That's harder to treat, not surprisingly. So there's been controversy around whether psychotherapy is effective. Remember, if you're doing a randomized control study, well, what are you comparing it to? Right? Are you comparing it to no treatment at all? Or are you comparing it to like a sham treatment? A sham treatment might be, let's say you have somebody that's depressed and you're going to have, let's say you're comparing, you want to know if cognitive behavioral therapy is effective. So in this group of depressed people, maybe half of them get cognitive behavioral therapy. And what are you going to compare that to? Leaving them alone with nothing? Okay, that's a no treatment control, but that doesn't account for the fact that there could be confounds. What if what's making the person better is just that they're getting attention? So how are you going to control for attention? How are you going to control for expectancy effects? Somebody might think that they might get better because they feel like they've done something about it. They're doing something about it. They might have some kind of cognitive dissonance where they spent so much money and time on the therapy that they make themselves feel better in order to justify the cost. So what can we do? Liam says, knowingly not treating someone as kind of unethical, the way that researchers get around that is they make a waitlist control. So there are not enough resources for everyone to get the therapy. We will provide the therapy to everyone. Let's compare those who get the therapy to those who are waitlisted. The waitlist controls are one way to get around. But obviously there's confounds with no treatment controls. Which is like, what about the expectancy effects? What about placebo effects? What about that they're getting attention? What about the fact they're just getting social support? And we know that social support makes people feel better. Well, you could come up with a kind of like a sham therapy. So maybe you have somebody come and they sit with somebody and they sort of like talk about their problem, but cognitive behavioral therapy is not performed. You don't engage in the techniques, the therapeutic techniques. Or maybe you don't talk about the problem and you just, I don't know, give them some kind of general support. Okay, so those are sham treatments could somehow control for a placebo effect. But you have to be careful that you didn't sneak anything in there that was actually mechanistic to the treatment. Another thing that's done is sometimes we compare a new treatment to an old treatment. So we know a lot about psychotherapy, the psychodynamic. There's been a lot of research on that. We could compare CBT to the old form of treatment, like comparing the new to the old to see if the new is any better. Does it offer any incremental value? So there's different ways to do this. There are many studies on this subject, and meta-analysis provides a way of combining the results. So you look for studies that are on a similar question, that are done in a similar way, and you combine the results, but in a way that adjusts for sample size. You want to give more weight to the studies that have bigger samples than to those that have smaller samples and that, you know, whose results are therefore less reliable. So that is done in a procedure called meta-analysis. And your textbook describes results of a famous meta-analysis where the results suggested that people who get psychotherapy tend to improve more than those who don't. But those who don't still tend to improve. Can you guys speculate or why? Why would it be the case that people who don't get therapy tend to improve anyway? And it's true. If you have an issue, you don't get treatment, like the average person, things will get better. The average untreated person improves. So this meta-analysis found that without therapy, the average untreated person improves. They get better. However, those who get psychotherapy tend to get better faster. They get even better. Why do you think it is? How come people who didn't get therapy didn't get worse or just not change at all? I'll let you guys sit with that as I move on. So psychotherapy, while it's effective on average across many different problems, there are cases, there are situations where therapy can be harmful. There is a concept of iatrogenic harm. Did I write that on the slide? I'll type it into the chat. Iatrogenic. Iatros is the ancient Greek word for doctor. Healer. And genic means created by. So sometimes harm can be created by the healer. There are therapies, there are programs that are known to make the problem worse. Okay? Facilitated communication for autism is bunk, right? That has caused serious harm. We talked about the Windrow case. There are programs that try to prevent delinquency or prevent drug use by getting police officers, say, to introduce students to sort of talk about why drugs are bad. You know, show them the drugs and you know, come in and tell them that's, you know, that's not what you should be doing. And these can, you know, backfire for so many reasons. If you are dealing with a marginalized community, what's the relationship with a police officer? It's coming in to tell them how they should behave. Maybe that community has a bad relationship with police. Maybe you have students who were not thinking about drugs and crime, and now you just had someone say, oh, you know, well, don't do drugs and crime, but by the way, it's really fun. and this is why people do it, right? You could give them an idea that they didn't have before. That can happen when people with eating disorders are put together in therapy groups. All of a sudden they start like trading and you know, seeing who's lost more weight, right? Sometimes they interact in a kind of negative way. Sometimes you know, in this sort of Scared Straight program, you introduce youth who are at risk to offenders. This may be happening in a context where those youth at risk actually don't have good options in mainstream society, right? They're looking at becoming a concrete spreader for minimum wage. Okay, their financial outcomes are possibly going to be a lot better by getting involved in crime, as long as they don't get caught. There are therapies that have killed people. This textbook opened with a tragic case of a little girl who died during some kind of rebirthing therapy that assumed that her issues would go away if she repeated the birthing experience, because this could have been trauma and now she has to work through it. She just died of suffocation. There are studies that suggest that there's a lot of kind of similarity in outcomes between different types of therapy. And there have been efforts to dismantle therapy to find out what works. And maybe what works isn't like the cognitive component or the behavioral component or the human, or the assumptions that it makes. Maybe there's core common factors. And Roger suggested, I think this has been empirically supported, but there are things like empathy. Right? You need somebody that is, you know, caring about the person and their problems. Right? That is therapeutic. A relationship with that person is like authentic, that provides feedback that's useful, and that helps the person see things from a different perspective. Basically, all the therapies can achieve that. There are many different kinds of therapy out there. Right now, here at St. Mary's University, it's accessibility. We can have therapy dogs. So students can go into the accessibility center and see a therapy dog. That's a kind of psychotherapy that involves a dog. Do dogs make people feel better? Maybe. So a clinical psychologist told me about a story where they thought they were going to bring a therapy dog into a group of depressed patients, and they had the depressed people in group therapy in a circle, and they brought in the dog, and the dog was all happy, tail wagging, running around between different people, and they're acting severely depressed, and the dog ended up just like laying down in the middle of the circle and kind of giving up. So it was like they made the dog become depressed. So I don't know if dog therapy is evidence-based or not. I know when I was going through really difficult things, I decided to get a trauma therapy cat, and I swear by the cat. You've seen her in some of my videos. What else? I have a friend who swears that horse therapy is really good for her son. Have there been studies on this? There's many other things. There's aromatherapy, and there's music therapy, and there's art therapy, and some of them are more evidence-based than others. But remember that the absence of evidence isn't the evidence of absence. Something can be work and be commonly used because it works, and yet nobody's done a study on it. Because doing studies is really expensive. You have to compensate, you have to find the participants. If they're not your intro psych students for getting course credit, then maybe you have to pay them. You have to pay the research assistants. It's going to take many months to do it. Who's paying you to do it? Maybe you have to be a full-time professor that's expected to do research. And what you research is connected to what your colleagues do and what your supervisor did. So there's many therapies out there that just haven't been tested because they haven't been tested. Maybe there's no financial incentive. Like, is anyone going to give a researcher a grant to go study that? There's a lot of research on biomedical therapies on antidepressants because there's pharmaceutical companies that are paying for that because it's in their interests to have their research out there. But in whose interests is like dog therapy? Right? There's no like dog union to fund that. So be aware that some therapies are more evidence-based than others, like obviously CBT more so than psychodynamic therapy. But there's many therapies out there that haven't been tested, and maybe they work, and maybe they don't, and maybe they even cause harm. And people can be fooled by ineffective therapies. I don't know if dog therapy is effective or not, but I doubt that Reiki therapy is effective because it's based on ideas about like energy fields and stuff that don't work scientifically. And this goes back, so you might wonder why. Why are we fooled by ineffective therapies? Or why do we use harmful therapies? And there's so many reasons for that. Take things like the DARE program where police come into schools. There are a lot of programs that are based on bullying. They're about bullying prevention and children and youth, or suicide prevention that could be ineffective or harmful. And in fact, if you have an ineffective intervention, let's say it just doesn't produce any improvement, in a way you're automatically doing harm because there's opportunity cost. Somebody could have been doing something else that might have helped, or it's getting in the way of whatever else they might be doing that could help them in their lives. If you're in a school teacher and you're running an ineffective program, well, how are your students' math scores? Maybe you should have been spending time on that. But often school administrators want some way to tell parents, they want some way to tell the media that, yeah, there's this problem with bullying, but, we're working on it. We have a program. There's a program. Yeah, parents are concerned about possible delinquency and drug use, but hey, we had these police officers come in and talk to the students. Oh, and then they take pictures of it. and they put the pictures in the newsletter. And so it all supports a kind of optics and politics of doing something that administrators may need or want to have, whether or not it really works. Suicide prevention programs can actually increase suicide rates. For example, they can make people think about suicide who wouldn't have been thinking about it otherwise. They can kind of glorify or glamorize suicide. Sometimes when there's a tragic loss, like say a teenager commits suicide, parents want to go to have assemblies and talk about their child, and like have like vigils and photographs, and it's reported in the media. All of that actually supports a process called suicide contagion. Let's say there's a depressed kid in the audience there, and they're thinking, I'm rejected. People think little of me, but maybe, if I did this, they'd be so sorry, right? Maybe there'd be these vigils and, people crying and say, oh, we wish this person was really wonderful and we wish they'd be treating them better. People want that, especially when they've been, say, bullied. And so those interventions, as heartfelt as they are, as much as they come from a place of wanting to do good, can actually do harm. So that's why it's really important to try to measure your effects rather than to assume that a program or a therapy is helping, right? Especially if you have an interest in presenting yourself as the helper or saying that things are being helped. Do some measure. See if it really works. See if it could be doing harm. So there are self-serving biases there. Now, you also know about placebo effects. People sometimes actually get a bit better just because of their expectation, just because of hope. And my opinion on placebo effects is that if you can acquire them safely and cheaply, go ahead and get one. Wear your Lucky Charm bracelet, carry your Lucky Pen. That makes things better for you, and there's no cost. But then sometimes people engage in placebo-based therapies that can be long-term harmful, maybe because you're not engaging in an effective treatment when you should be. I think of an example of a man whose father died of type 1 untreated diabetes because while he was the sun was shining a yellow light on him because of the Reiki stuff about chakras and color. I had asked you, why is it that people who aren't treated do tend to get better? And one reason could be spontaneous remission. Just because somebody's very anxious now, or even suicidal now, or very depressed now, doesn't mean they're doomed to spend the rest of their life like that. It might resolve on its own with no intervention. And cancers go into remission. And then there is a phenomenon called regression to the mean. And this is tricky to explain, but I think I can do it. Imagine a normal, so if something bad happens, you're in a certain state. There's reasons for why you're in that situation, and some of them are based on chance. Say you're in a really, really bad place now. Maybe luck was against you and fortune was against you in some ways. Something happened that made you become sleep deprived. Your boyfriend broke up with you. This was also when there was layoffs at your company. You bombed your exam when normally you do well because of all these things. So imagine a kind of a pile-on of negative outcomes that are partly due to chance. Well, think of the effects of chances themselves sort of normally distributed, and you're way out there on the super bad luck tail. Well, it's likely that your luck will revert sort of back to the mean. So if you let's say that I picked students with the lowest scores on the midterm, right? The ones of like 25%, 30%. Chances are that there were many bad luck factors that went into that negative outcome that would not repeat if they were tested again. Maybe nothing happens, there's no intervention. I just let them write the same midterm again, but now they don't have that fluke headache, right? That sudden breakup, and they do better with no intervention. That's called regression to the mean. The last one is retrospective rewriting of the past. I'm going to relate this back to cognitive dissonance. So let's say that you had this problem and then you spent all kinds of time and money on therapy. That's a big effort. Do you need to justify to yourself that this was all worth it? Would you feel distressed if, let's say, there was no real change? And could you acknowledge to yourself it was all a big waste? You might not want to do that. So it might feel better to tell yourself that you were helped by kind of retrospectively rewriting the past. Maybe, you had some distress, but it wasn't such a big deal. And now you look back at your time before therapy, it was so awful. It was so terrible. I was so dysfunctional. What if you're telling yourself that story in order to feel better about what you're doing now? I would not put that past the human mind. We are at 12:19, and I'm going to move on to biomedical treatments, and I will continue lecturing past 12:20 in order to complete the presentation. So, biomedical treatments are often drug therapies that work on some sort of neurotransmitter system. So if dopamine is the problem, you could sort of upregulate or downregulate that with some pharmacological intervention. But not all biomedical therapies are pharmacological. Lifestyle change is a biomedical therapy. Improving your exercise, improving your sleep, improving your diet. Those are all biomedical therapies. And I would say they probably should even be a first line before you consider the ones that are a bit riskier. So we know that these therapies in many cases seem to work, right? There are many people who are helped by antidepressants, but we might not exactly know how that works, right? Because our understanding of how neurotransmitters work and how this relates to psychological disorders is pretty sketchy. Okay, so we might not completely understand how this works. We know that depression has something to do with serotonin, but it's not as simple as just increasing serotonin, though that can work to some effects. Many medications have adverse effects. I highlighted this because it's a very common misuse of a term. I used to teach in pharmacy, and pharmacy students had to learn the difference between side effects and adverse effects. A side effect is an effect of a medication, is not the intended purpose of the medication. There's a medication called domperidone that's for digestion, and as a side effect, it increases milk flow, like breast milk. And so women who struggle to produce enough breast milk are prescribed domperidone off-label because of this desirable side effect of creating more breast milk. So a side effect is just an unintended effect of the treatment, but it may or may not be bad. When it's bad, it's an adverse effect. And it does bear thinking about those. And an adverse effect may impact you now, or it may impact you much later, or may impact you under certain conditions and interactions with other, say, drugs you're taking or things you're doing, including your diet. Oftentimes people who take a pharmacological therapy will have some adverse effects at first that then kind of wear off. However, there are drugs that can cause adverse effects later down the road, like say tardive dyskinesia is an undesirable outcome of antipsychotic medications. When people die because of medications they were taking, it's often a situation where they're combining multiple prescription medications and even combining prescription medications with non-prescription medications, like over-the-counter stuff, say cold medication, and then with like recreational drugs as well, like say alcohol or marijuana. And that whole combination can be bigger than your body can handle. And that's often the case when you hear about these sort of celebrities who die young. I think I've already covered this material. So to make the point that, it's not like sort of drugs versus psychotherapy. Sometimes they can be combined together very effectively. And you'd want to think about pharmacological therapies if psychotherapy has failed, if if lifestyle change has all failed and there's still an issue, maybe it's time to treat that pharmacologically. And remember, if you're a psychologist or a counselor, you can't prescribe that medication. That would be prescribed, it would refer the person to a doctor, or back to their family doctor even, or to a psychiatrist in order to make the prescription. Then there are biomedical therapies that are more than pharmacological, right? They can be surgical. And a famous one is electroconvulsive therapy. It has a bad rap from that movie with Jack Nicholson in it, One Flew Over the Cuckoo's Nest. This is kind of like one of the last lines of defense for severe depression, though it actually can help people. Maybe there's some way that, your neurons are misfiring and they need a bit of a reset, right? It actually can be an effective treatment for severe problems, but it's not the first thing that you try. And then there's other forms of stimulation, like an electrode in somebody's brain. That's called deep brain stimulation. There can be things like transcranial magnetic stimulation. So there's other biomedical therapies that are not pharmacological. The most extreme would be psychosurgery. And you've probably all heard of lobotomy. That was a bad kind of psychosurgery. But there's situations where, let's say to treat severe epilepsy, surgeons will cut the corpus callosum so that the left and the right side of the brains can't communicate anymore. All right, that's psychosurgery. And again, that's the last thing that you do if nothing else is working, because it's obviously, it would be irreversible. It is 12:25. Thank you for your patience. I'm going to stop the recording here, and I'm happy to hang around to take any questions you may have.